to come and teach us about gut health, the other brain. And I've known Melissa for a while now, and Melissa is a very highly esteemed lactation consultant here in Portland. And through my contact with you in my classes, I have realized that Melissa knows a ton about gut health and how it impacts maternal and infant health, and she's here to share some pearls of wisdom with us, and I'm so glad that you're here. I've bugged you for a long time to do this presentation. I'm so glad you're
First I
here.
said, oh, maybe I can do tongue talk. Oh no, someone's doing that. Maybe I can do breast, someone else is doing that. So I just do the poop talk, because it's kind of like the left hand. I do too.
Yeah, so you can give us the straight shit.
And I have no brain exercises for you. There's no big words, so it's a good one. You can zone out. I'm not going to test your any knowledge after this. And it really is meant to be Gut Health 101. This is sort of the Cliff Notes version. But we see so many moms and babies that they're miserable. Everybody's miserable, and there's more to it than just the vagus nerve. Although I'm not going to underestimate that. So I am really thrilled to do this one. It's the first time I've done this, and so I'm going to hopefully not go on too many tangents so we can stay on track of time. But to add and continue sort of the mindfulness work we've been doing, tuning into the body, I will often talk to my body. And I like to tell my gut, really thank you for all the hard work, digesting my food, and assimilating nutrients, and I had a little brainstorm this morning, and every time I do that with myself, I always get a little initial clench before I get a soften. And so I always was telling myself, well, I better work on this more because I'm always getting a clench, and so I've got to work on just loosening that a little bit. And then this morning I had just this miracle moment where I'm like, no, that clench is my gut's you're welcome. I'm working so hard for you. And I realized that's my solar plexus feels really male energy to me, and it was just natural that it wanted to salute. And it's layers of muscle, and heck, it has all that gastric juice. It better be strong. So yeah, I had a little body awareness this morning. I'm feeling okay with that clench. So just in sort of defining this, kind of saying, well, what is gut health? Various cultures respect the gut much more than we do, and have various ways of defining it. I'm just sort of going to incorporate some ideals from Bischoff's work. He's a German gut health guy, and I think he has some good basics that will help us just with this presentation. Gut health can mean to us effective digestion and absorption, the absence of GI illness, normal and stable microbiota. It's not just bacteria, right? There are viruses and all kinds of cool things in there that all work in harmony. Effective immune status, right, and a state of well-being. So gut health incorporates a lot of things. It's not just about pooping or reflux and things like that when we think of babies. All right. I'm going to kind of scroll through this so we can get to the fun stuff at the end. But just having a basic awareness that in embryological development, the gut, much like the ventricles and all these things we're talking about, they form at really an early time period, a really sensitive stage of midline formation, and often before moms even know they're pregnant. And by the 8th week or so, give or take, this gut tube has started to, from the mouth to the anus is starting to open, and really the fetus, is starting to swallow amniotic fluid somewhere around week 10. Give or take, everybody has different ideas about this. But the glandular organs are really budding off of this. So really understanding how intensely connected, the endocrine system is. You just can't separate it. Okay. And also keeping in mind that oftentimes at this phase of embryo developing, if something's majorly wrong, oftentimes the body will release that pregnancy and prepare for another one. But sometimes minor stuff slips by, right? So we've got clefts, the tongue tie, lip tie, different things. There can be fistulas, tracheoesophageal fistulas, and different things going on. And different areas can either be narrowed or fully closed up, but yet still be capable of life. So we just might have a baby that's dealing with some abnormalities. Okay. So some of this might be new to you, some of it might not be new to you, but my big thing that I really like to push is that the infant gut is not sterile. And I think a lot of times we're really in this mindset, oh, it's sterile, it's sterile, it's sterile. They come out through the vaginal canal and they get all colonized. But no, the infant gut, through the work, there's some cool researchers in Spain, Esther Jimenez and her team, testing like, what's in that amniotic fluid, what's in the meconium, and finding out, the bacterial colonies that are actually there and present, which is why we've got to address babies' gut health preconception through mom. So we've got to get these moms healthy so they can have healthy babies. And the gut flora and these bacteria and viruses, they don't just have one role to play. They don't just help with digestion. They talk to each other, and different things, whether it's medications or nutrient input, genetics, make these things work in different ways. So again, another hard thing to study, right? Because there's so many different things that can impact how this gut flora wants to work. And then we all know, at least we should, that the root of all evil with inflammation, the gut is one of the main things that sort of sets us off or protects us against it. And so we really have to, and the cool stuff coming out with autoimmune stuff and autism and whatnot, and its relation to gut health. Okay, so kind of coming off of Lisa's wave, our second brain in our gut, our second brain is often the gut and the enteric nervous system. And to think of it as really a second brain, the gut is lined with millions of neurons. They're all in there talking to each other, working together. And these neurons, while they can work independently from the central nervous system, although they usually work all together, they do things. They control peristalsis, the release of enzymes. So if the vagus nerve were severed, the gut could kind of still keep on plugging along, doing its job. Not that other bad things wouldn't happen if the vagus nerve was severed, but it can kind of keep its own thing going. And it's really cool to know how sensitive this is to the maternal environment. Neat research on how SSRIs, maternal antidepressant usage, nutritional status, and gene expression is impacting the infant's ENS development. So, yeah, we want stable moms, healthy moms, moms that can cope with the realities of pregnancy and having a baby. But on the other flip side, we really don't know what we're messing with. So we've got to balance risk, benefit, and just be aware. And then on the endocrine side of things and working with different neurotransmitters, over 90% of the body's serotonin and 50% of the dopamine are found in the gut. Like, so much of it released in the bloodstream, you die. But, it's got a lot of things to do there. And also, the quality of one's diet and nutritional factors certainly, and this seems like, well, yeah, of course, to us, but to other people in various fields, really, I work with pediatric gastroenterologists dialoguing about what this baby needs, and they don't get the whole what goes in and packs everything along the way for a lot of cases. So, of course, we know it does. Okay, so just kind of giving breast milk a little bit of a credit here. The gut expects human milk, right? Human babies expect human milk. And there's so much about breast milk we don't know yet. A few things we do know is that it promotes the growth of biofilms that coat and protect, and that it contains really food for good bacteria. So a lot of what's in the breast milk isn't necessarily good bacteria, but a lot of it is food for the good bacteria. So that's really important. And that's why you start to see these keywords of prebiotics, this formula has this and that, because they think they can copy breast milk, and it's not going to be the same ever. And of course, the secretory IgA that helps develop the mucosa, and it helps develop actually neurons in the gut. So it has actually a multifactorial way of working within the gut. Of course, it has some good bacteria. There are certain bacteria that will pass through breast milk and certain ones that don't. It's not like mom can take a probiotic and everything that's in that probiotic goes through, but some bacteria do, and so that's still being discussed. So certainly there's some crossover and then some things that don't cross over through the milk directly. Right, so the infant, what does the infant expect? They expect mom's gut to be healthy, okay? Their flora is primarily from mom, both prenatally and beyond. So, from the time they're growing in utero, through passing out the birth canal, or however they're born, being placed on mom's chest, getting colonized there, through the breast milk, it's just continuing, builds upon each step. And if a mom obviously has her own gut issues, and she's passing through bothersome things to her baby, whose gut is naturally immature, we kind of want it to be so good stuff can pass through, but then we kind of don't want it to be because bad stuff passes through too. So the more compromised mom is, a double whammy happens for baby.
Okay. Excuse me, are you talking about prenatally when the mom is pregnant or after?
Both. Oh, well, you mean about the infant gut, or?
If the mom has a leaky gut, how does the bothersome proteins get through to the baby?
Because we know that mom's gut flora is impacting the womb environment,
right.
That there's things in the amniotic fluid, because, we can see what's in the meconium, which is, what baby has swallowed. And certainly, the more beneficial flora baby gets in the womb, the better. But so if mom's gut flora is compromised, and then she gets ton of antibiotics in delivery, and so prenatally, mom's flora, good or bad, can impact baby, and which is why we have to get past the whole gut sterile thing, because it really starts with getting the mom healthy. So, most of all of us, we're seeing the situations where, okay, well, the perfect scenario did not happen, and now we're doing the cleanup. So what can we do around that? Okay, so just a couple things, just to know, healthy gut, unhealthy gut's not just spit up, not spit up, poop, no poop, but, there's a whole spectrum of what we can look at. And I kind of think of, here's some signs, it's not comprehensive by any means, but if stooling's regular and easy versus infrequent or strained or mucousy with undigested food or really gassy, it's kind of normal, not normal. Babies with eczema, rashes, and yeast, this is not just a slap a topical steroid on it, this is coming from within. Big thing here with sleep. I get a lot of parents who are like, my baby never sleeps. And I always kind of check in with the gut first, because when we're talking about like mucus in the eustachian tubes and babies kind of waking themselves up because they're not happy, they're producing like over excessive mucus, like waking themselves up to kind of stabilize that, and we're just physically uncomfortable. So these are often unhappy babies, okay? And often the other end of the spectrum are babies that really, they might be getting enough food, but they're not able to absorb it. They're not able to use the nutrients properly. They might have different deficiencies, whether it's clinical or not. All right. And just my little 2 cents, that I really feel that it's, why are we seeing more of these things? Because we have a more toxic world, but we're seeing, I think, generation upon generation of compromised flora being passed on, and the healing process never being able to happen, and different things, epigenetics is teaching us cool things. So, where can we start to just make little inroads in breaking that cycle? Okay. And so, I think one of the things, if we're working with a lot of moms and babies, a lot of times people are coming to us because their babies are uncomfortable, they're fussy, right? They're not happy. So we have to have some basic understanding, and I realize not everybody here does infant feeding, but you have to have some basic awareness of what's normal intake, what's normal growth, what's normal, so are you treating a baby that's actually hungry and needs food? Or are you treating a baby that's well-fed and just miserable for some other reason? So I really stress that. I see a lot of people refer to me, oh, my baby's fussy, oh, they're gassy, They're starving. So we really always want to tease out when we're looking at gut stuff, is baby being fed enough food? It's kind of like number one thing. And really, work with a team to help deal with that. Okay. So, and please note, my little citations at the end, it's not like comprehensive or the only person who's done work on it, it's just kind of a little starting point. But there's more people who've done work on all of this stuff. But the fetus drinks about 10 ml portions of amniotic fluid at any given time, and that newborn tummy at birth has a capacity to hold about 10 to 15 mils, give or take. And it's not super stretchy. We know that really the gastric relaxation and increased capacity doesn't really kick in until about the 3rd day postpartum. And from there we can get into trouble because then the gut can be unhealthily stretched out. And we start giving these babies these big feeds that their gut's not ready for, and we can keep stretching it and just think of all the lifetime issues we're setting our little ones up to expect, these like huge meals before their body feels satiated. So yeah, I see these 8-ounce jumbo bottles in the stores. Like, no baby ever needs a bottle of anything that big. So we want to just kind of know what's appropriate amounts of intake for that baby. Okay. So just for those of you that don't do feeding stuff, to have an idea, if you're asking a mom, so how much does your baby eat? How much do you give your baby in a bottle? And, and if someone tells me, she loves 8-ounce bottles all the time, I'm like, oh, okay, we've got to backtrack a little bit. So, again, we're not going to go through each and every number, but this is average, and I love having Lucy here because you can kind of see the biologic norm of, 8 to 12, and I say plus feeds a day because it's normal that a baby's going to want to go on, every hour. And the difference from like Lucy compared to a baby that's really struggling, it's I'm nursing, I'm sleeping, this is good, I want to nurse a little more, versus like, I'm eating, but I'm stopping because I'm fatigued. But wait, I'm not done, I gotta eat more, but I'm fatigued. So there's very different patterns and frequency. So if a mom tells you, my baby wants to eat all the time, you need to go deeper with, well, what's all the time? For some moms, it's like, 6 times a day, it's all the time. And then for some, it's like, well, no, I can't get off my sofa, the baby's on all the time, literally. So again, asking those detailed questions of what's all the time for that mom. Okay, and again, sort of the World Health Organization growth standards, which we can talk more in detail about later. Sort of, this is kind of what we want to see a baby gaining, give or take a little bit. And certainly weight is not the only tool. Like Carol said and others have said, we always focus on like that as the standard of health, like if they're gaining. And also with preemies in the NICU, like this is the only thing they're pushing for, fatten them up, get them out, fatten them up, get them out. And, most people would rather see kind of lean growth that's appropriate, that's growing big brains versus growing big other body parts. And I'm not going to go through this too much, but just kind of know if a baby needs more food, there's sort of a hierarchy that we might kind of look to protect gut health and kind of know, gosh, can we always get more of mom's milk? If not, can we get more of somebody else's milk? And all of these things have steps and a way to dialogue about informed consent so that moms and families can ultimately, sort of pick and choose what's available, what they feel safe with, and to kind of work with someone knowledgeable about infant feeding. But, I will say there's many times when babies need more food than they're getting, and we need to work as a team. Okay. So, I think if someone was asking Allison about, poop and what's normal. Infants, all people should be pooping every day, and in many cultures it's every meal. Okay, and not just the babies, but the adults, every meal. So again, what's common or what's normal needs to be teased out. So we really want to kind of take away that idea that, breast milk is so easily digested, babies just digest it all, and they have nothing left to excrete, and so your baby that hasn't pooped for 10 days, that's normal because they're breastfed. No. So, just kind of in the early days, obviously sort of a void stool per day of life, kind of that first week is kind of a mark some people use, and sometimes it plateaus after that and shifts baby per baby. But, not stooling multiple times every day is not normal. All right, so just a little bit of detective work, and for people like me that spend a couple hours per session, I'm bound to get to see a diaper. So they're in there, please don't throw it away yet. We want to look in there, see what's going on. And if a mom is changing her baby in your office, like, please take a look, see what's in there, and start to get used to what's normal, not normal. So scant stooling, infrequent stooling, it's definitely a sign. We want to kind of check in with that, make sure baby's getting fed enough, and eliminate inflammatory triggers and compression. Mucousy snot-like stool. Normally our body does produce some mucus to glide and slide and pass stool along. But really, when you open a baby's diaper and it's like somebody blew their nose in there and it's snotty and it's stringy and you can kind of peel it apart and the strings are kind of separating. That's mucousy, and the body, right, makes mucus to coat an irritant and get it out. So why is that baby so mucousy? Bloody, everyone freaks about blood in the stool. It's most of the time not a big deal, but it's a sign that the gut's irritated by something. And certainly, you know, I'm not going to say that don't go to your healthcare provider, do, but also taking baby off breast milk as the first strategy, you know, is often not the best first strategy. So really, if someone's suggesting a baby do a trial run of formula, I would question that, get a second opinion. There are very, very few times you would actually not want a baby on breast milk. We'll talk about those later. Green lettuce-like stool, you know, moms will Google themselves crazy and think, oh, I got this square milk, high milk imbalance, blah, blah, blah. Very few times is that really the case. So I kind of take green stool in sort of the rainbow spectrum of what's normal, and some green is a little normal, versus it looks like lettuce in the diaper. It's like undigested leafy greens in the diaper. So really, actually, when moms are saying, oh, they've got green food, again, go further. Oh, what does it look like? Does it look like you maybe had a salad for lunch? Oh, that's just kind of green in hue. So different, okay? Again, moms don't necessarily see a lot of other babies poop. Okay, of course, anything on the bottom, you know, really pasty white, gray stools. Certainly this could be a possible bile obstruction. That's, you know, medical emergency. No stooling or passing meth. Absolutely, they get to go to the ER. And I had a case, I don't know, 6 months ago. Home birth, like 9th baby, you know, had it 4th day, I was called in, they hadn't pooped, not even meconium. Midwife saying, oh no, please, you know, get some help, and the DO was saying, oh, there's no problem here, it's just a breastfed baby. This baby, of course, she had Hirschsprung's, and it's, you know, obviously nerve issues where they cannot pass the stool through the colon. So, you know, if they say, oh, my baby's not stooling, but they did pass meconium, at least we know the pipes are probably working somewhat, but not passing poop at all is obviously medical emergency.
I had a baby at 5 weeks have bloody stool, and she had salmonella.
Yep, yeah, don't ignore. It's better to be safe than sorry, too.
I was like, I don't know,
Yeah.
it doesn't seem good if you need to go
Right.
in.
So if they go in and they do all the testing, they're like, nothing's wrong,
They did
but let's do a
exactly.
trial off of breast milk. That's different than like, oh my gosh, we did the testing and this is the problem. Yeah, that's very different. Okay. So I'm not gonna, you can read this all in your own time, but there's a few cool studies, and you know, I'm always looking for like studies and what can I find. And you know, a lot of the ones that are done like with a population of US babies, it's like, how valid is that? Because you're studying a compromised population. So like, I want to know what's normal, you know, about pooping. Oops, no, we don't want to. Oh, can you click that off for me?
Yeah.
Use the mouse on the side. Thanks. Okay. And can you pull the arrow back down for me?
What's that?
Can you pull? Oh, it went away. Never mind.
No, okay.
So a couple of the patterns, like from a Nigerian study and a Thailand study, you know, I think they probably are a little bit closer to having a normal diet, perhaps. Definitely shows more frequent stooling than the studies done on American babies. And we can't say like, whoa, their culture is going to poop more. No, I think we can kind of extrapolate these studies to that level. And infrequent stooling related to colic development. Again, it really shouldn't be news to us, but infants having colic symptoms in the first 2 months of life have less frequent defecation during the first 2 years of life. So there's, you know, absolutely relationships between miserable, fussy, screaming babies not pooping, okay? So you can read that in your handout. All right. And so again, I just want to put that reminder, that awareness that infrequent pooping is not normal, okay? It might be common, but it's not normal. And breastfed babies don't just use up all the energy. And really, we know that the patterns of healthy peristalsis and moving food and fluids through the fetus happen early, well before the baby is out of womb, unless we're talking about a very premature baby. But really, any baby past 30 weeks really should be able to tolerate oral feeds, and for various reasons, some are not. But that gut system should be functional by then. So, we're not going to talk talk about everything done, because that's a whole conference, but I just wanted to bring in a few support strategies for maybe the clientele and the patients that we see, so that we can kind of just, take some general ideas and roll with them in a practical way. And so we see so many babies in, and they've got colic, and then, somebody diagnosed with reflux, or they're just fussy. So I'm going to look at this as sort of an umbrella of colic, reflux, fussiness together instead of compartmentalizing it. Okay. But just to kind of define it, I think a lot of babies with reflux now, 20 years ago, they would just be labeled colic. So these are sort of the definitions. Your colic, crying for more than 3 hours a day, that lasts for more than 3 days a week, more than 3 weeks. Okay, I get a little definition here. And then reflux, is it disease or is it just reflux? Knowing that it's really just talking about food coming back up or down, but does it irritate or inflame or damage the tissues or cause feeding issues for babies? And again, like so many diagnoses, these kind of just get slapped around, and then we kind of get in a mindset of, oh, this is what I'm dealing with, so this is what I should focus on. And luckily, we're all aware of just kind of following our hearts and our hands and looking at the bigger picture. Okay. All right. So, with these miserable, spitty, unhappy babies, what are some of the things that could be going on? Certainly, we've spent a good portion of the last few days talking about birth trauma, neuromuscular impingements, other types of oral restrictions and issues that can cause babies to be fussy. And actually, do note that they're, I love the whole valve concept, because babies often do have immature valves just by nature, because they're not fully cloaked on the outside. So these little esophageal sphincters and valves are kind of loosey-goosey, and a little bit of food coming up and down isn't a bad thing, it happens sometimes. So that's different than like a pathological sort of reflux. So also food sensitivities, whether it's mom, baby, both, they can be various kinds. On infants, if I'm doing any testing, I'll refer out to more holistic testing. Mostly allopathic allergy testing doesn't tell us so much for these types of issues. But food sensitivities, feeding issues, is the flow too fast, too slow? How's this baby working? Moms that are using a real rigid schedule, again, is this baby fussy because they're hungry? Okay, too much milk, too little milk. Sensory, okay, I've been talking a lot about that. Mom might have, this is a big one I come across. Mom has a normal flow. Baby's gagging, choking, spitting on this flow. Mom thinks, oh, I better downregulate my flow. It's too fast. Everybody thinks I have a fast letdown. No, your letdown's fine. It's your baby having trouble with normal. So you always have to be careful. It's much easier to downregulate a milk supply than upregulate it. So all these moms are like, oh, I've got 4 milk high milk issues, so I'm going to nurse 5 minutes and off, and they're doing all these crazy things that we always have to know, kind of like, you got to do the diet as a whole, and maybe it's baby having trouble with normal. And health, hearing and vision issues. I love Carol's work with the hearing screens. One of the most interesting cases I had about a year ago was a little one who was a fussy feeder. Her mom came to me, she thought, oh, she must have food allergies and sensitivities. Oh, she had some of that going on. But she made this sound and these cries that, like, my gut went to like neurologic, right? I wasn't sure, so I worked with the pediatrician a little bit, but she'd have some stridor and a little bit of, and she'd cry with, just these different sounds that as a practitioner when you see a lot of babies like that, something's off. Like, well, what do we do? To just swallow steady, like, where's this issue coming from? And sure enough, she fed like 3 hearing screens, and she was so disoriented with sound. She couldn't hear, first of all, and no wonder her cry sounded off, but it was a hearing issue. And there wasn't food allergies, right? So again, we're going to step back, and cutting out dairy would have done nothing for the for the baby who was like freaking out because they were so disoriented in their space. Malabsorption issues, see this a lot, and then the rest of bigger issues there. Okay, and one of my favorite healing modalities for gut stuff is Chinese medicine. And there's some great people in the Portland area that work with babies, and that whole stomach-spleen connection is great for babies. Yeah, Allison.
So, I don't know about how your water quality is here, but in my town, our water quality is really terrible,
Yeah.
and I see a lot of babies with parasites.
Parasites, it's a big one. Yeah, and I think that all of that, yeah. And I think that an interesting thing is, I'm curious, do you see it in testing, or you just see that that's probably what's going on?
No, we
See it
have
like a
them
people
tested.
test? Yeah,
Mhm.
yeah.
We have some that's headphone in the country.
Do you?
Yeah. It depends on, I think, where you are here, but we get our share of bacteria, parasite scares with our nice open water systems here.
Yeah, our open reservoirs.
Yeah, yeah, that's a great point. But certainly, yeah, parasites.
How
So
does
Chinese medicine.
malabsorption present? How do you-
Well, it's the kiddo that maybe isn't gaining. Maybe they're showing up as not gaining well, but when you look at everything, it's like they're getting enough intake, you know, that they're nursing well. What's going on? And so, and we're going to kind of piece apart all of these. But yeah, malabsorption. And in older kids and babies, that often presents much more than, say, like an. Okay, so I am the type of practitioner, like I never say no to anything, so there's always going to be a time and a place for something, a tool, a med, something. So I like to keep a broad mind about all this. You know, but in this type of situation with most gut health issues, I think most conventional treatments, and by conventional I mean like allopathic, really they act as a Band-Aid, and sometimes we need a Band-Aid, sometimes we need baby's esophagus to stop burning long enough so they can remember like, oh yeah, I don't have to be in pain to eat. You know, sometimes that's okay, but you know, we always have to know there's risks, benefits with any approach, whatever it is. And we can never separate the mom and baby, so yeah, you can't compartmentalize baby's gut health without realizing, even a baby not necessarily breastfeeding, they're still sharing flora, sharing things together. And also as providers, if you maybe have never had a colicky refluxy baby or anything, it's kind of, what's the big deal? We can slap a bib on that baby and get on with life. And you don't realize like the emotional, physical roller coaster these parents go through, like hell and back to deal with a baby who's like never happy, and they're always dealing with feeding issues and baby issues that they've never even been able to enjoy having a new baby. So some of the work we can do is just having that healing presence for them, to have them feel safe and just acknowledge how much it sucks to be in their shoes right now. Okay, so a few things, anatomical things that impact gut health. We've seen the plagiocephaly and the cranial asymmetries throughout some various talks. Certainly some oral restrictions, come into play. So again, I'm so glad Allison was here to speak, because probably, 5 years ago, it was like my life's work to increase awareness about tongue tie. And now I feel like I'm on the backslash of that, and saying, everybody's coming to me saying, oh, my baby must be tongue tied. And now I'm kind of saying, no, there's some other things going on. So we want to have awareness, but we also don't want to get label happy and start to go crazy thinking that one label is the answer for everything. That certainly does impact babies that cannot cup, and they're breaking the seal, they're getting in more air, and that's not great. And then certainly we're looking at all those connective tissues and how they go from the tip to the top and all around. So those are certainly going to come into play. And I like kind of different types of body work for different people, different babies. A little bit of different types of work can go a long way. Bowen therapy has been a really cool one. I don't do it myself, but a few people in town do. Certainly craniosacral. Chinese, most of the Chinese medicine providers I refer to, they're not needling babies, but they're teaching parents, hey, here's some pressure points you can work on at home, and here's some massage techniques. So they're really showing and empowering parents, just like Doris and Nancy, like, hey, you can do some of this at home, and giving the power back. It's not always like, here, help my baby, but hey, you can help your baby too. And a lot of times, it's the tincture of time, which is the hardest, till some little sphincters mature, till some things kind of grow up and out. That kind of sometimes waiting it out is so hard. But in some severe cases, maybe there's some microaspiration happening, maybe baby's getting pneumonia from doing this, sometimes we certainly need additional testing, video fluoroscopic swallow study, baby getting scoped to see what's going wonky where. But these are kind of invasive things, so you want to do it when you have to, but not just as sort of willy-nilly of, oh, your baby spit up, let's stick a scope down. So, we just want to be judicious about our tests. Okay. And kind of scrolling into the food stuff, I'm sure you're no stranger to Wendell Berry's comment there. But it's true, we have such a disconnect in the Western view of like, oh, we just put it in, it goes down the tube, comes out the other end, does nothing in between. And we know that it's not like that at all. And certainly, working with moms and families, and the art of the intake, right, the health history, getting information and really working with moms to identify what maybe has been a chronic thing for them and what's trying to, it's like moms, they'll have, IBS and autoimmune stuff, and they're like flabbergasted their baby has some gut issues. It's like, well, let's look at the family patterns here. And then, sometimes with some of those families where maybe doing an elimination approach, maybe we've eliminated some things and it's not helping, or maybe mom needs a kick to consider eliminating something. They maybe need like a piece of paper with proof of like, here, eliminate these things, or they won't do it. It's not enough for me just to say like, hey, what do you think about cutting out the dairy this week? Or they need like it in writing. And so some of those families, can really benefit from allergy testing. Or families that they've, done a bunch of work and there's still some outlier they can't figure out, might do some fine tuning. But I will say I'm very picky with who I refer to for this kind of work. And I always like blind test people. Like I'll send my husband who's like, anaphylactic peanuts, so like he's got like real stuff. I'm like, if they can't pick up on his allergies, like no way am I sending a baby to him. So know who you refer to and don't just say like, oh, the person up the block says they do this, so now I'm going to say, because your referrals reflect on you, and you don't want to send moms on a wild goose chase because they're already so depleted on many levels. And for the do-it-yourselfers, directlabs.com and other labs, there are other labs for hair and fecal testing that you can send your own little sample and you get the results. And there are the same things for lab work, and you're not obviously drawing your own blood, but they will send orders into a lab. You go, you do the blood work, it goes to the company, and then they send you the results for you to either share with your provider or to work with on your own. So there are some things like that. And then just some basics, that we all know about, the basics: dairy, soy, nuts, gluten, eggs, citrus, nightshade, sugar, and then stuff outside of that. And these things, so food sensitive, I didn't put any citations here, but there are studies on increased night waking, bruxism, tooth grinding with food allergies. Okay, and again, I think this comes back to the mucus connection. In my experience, like babies are always trying to like pop their ears like they're on an airplane. They're grinding. There's other reasons for tooth grinding, but certainly food sensitivities can be one of them. Okay. Oh, and mood. Sometimes babies are not necessarily pooping weird or spitting weird, but even like with older people and adults, it's often a mood or a behavioral shift. We know with gluten, the rage, might not necessarily mean you're not stooling normally, but your behavior can shift because we know, like, right, all those neurotransmitters are doing things. Allison?
Well, I was just going to comment that there's a more direct pathway on the sympathetic nervous system. And of course, jaw clench is, a sign that the sympathetic is triggered. So you get the inflammation from the sensitivity or the allergy, and you set off the sympathetic nervous system.
Yeah, absolutely. And that's why we don't want to look at this. We don't want to overcomplicate it so that we're like scared of it, but we can't not look at every layer. Okay. Feeding issues, sometimes it is. I wish I just got the ones that was like, oh, we fixed the latch and you're good to go. I don't really get those moms in. But, working on fine-tuning positioning. We, of course, won't have time today, but this mom and baby up in the corner. Baby's just, I don't swaddle really, but that for feeds, but this baby was like achy and cold, so put a little blanket around, but hands like around mom, and he's laying on mom. But one of these days, you can grab me at lunch, and there's a very cool video I have of them, and this was a guy referred to me for reflux stuff and kind of managing that. And this little baby, nurse, Papa. And mom's like shoving him around, come on, get back over there. refluxing, you know, mom has a fast flow, right, because the baby's popping off, taking breaths. Now this baby had some major stuff going on. Nothing that needed surgery per se, but, you know, teaching moms that, hey, maybe your baby needs a breathing break. Let's not shut their head back on. Let's give them a moment. All right. They breathe. Okay, let's continue. But moms aren't necessarily aware that why isn't he staying on? But kind of teaching moms like, oh look, he's taking a breathing break. There's all these stress signs going, and really showing moms like, look, he's kind of stressed out now. Okay, he's ready for some more. You know, he's done some catch-up breathing, and we've got him in a safe position to protect his airway. So, you know, moms always think it's them, right? Like, it's my flow, it's something I ate, and so often it's really the baby. And I can't really, you know, say it enough to make sure baby's getting enough to eat, because I see a lot of babies who just really aren't getting fed, you know. Okay. I'm not going to go too far in the sensory stuff because we had so many great people talk so much better about that than I ever could. But, you know, different babies need different types of sensory input. Some need more, some need less. And, you know, we just kind of have to know what type of baby we're working with. There's mixed research on swaddling, and I feel like it works with some babies, it doesn't work with some, and it just depends on what the baby needs. But certainly, you know, helping reorganize the nervous system so they can settle enough to get into their feeding zone and feed in an organized way so they're not gulping air and then worsening their tummy troubles, right? Okay, and all that tummy time that we've learned about, all the sensory stuff, it's going to help aid the proper release of good digestive hormones. We'll talk about those in just a second. Gastrin, cholecystectomy, and different things that we need to help us know, wow, I feel full. Okay, this sets off a whole process. We'll talk about that in a sec. And this is why non-nutritive sucking, and that's why, you know, babies, preemies in the NICU and incubators, they often do need something to suck on, and, you know, and sadly they do get, you know, bruised from pacifiers and whatnot, but non-nutritive sucking is vital, so vital. And also baby wearing and tactile stimulation. You've got to have that for growth and for the release of digestive hormones. So just to identify, look, we've got another peace sign going on. So all these peace signs. Anyway, so just kind of this was part of another respiratory health talk I did. This is up on top, a shot of a baby with some laryngeal malacia. It's got softening of the larynx. Look at this floppy epiglottis, this inflamed tissue, this like straw-sized hole this baby has to breathe out of. And imagine how this baby might eat. Imagine if you had to breathe through a straw. Oh, I gotta eat, I gotta breathe, and it's hard work, and we get it, and these hard things. And a lot of times moms are like, oh, I've got too much milk, it must be the ice cream I had last night. So we have to know how to tease out what's a health thing, like what's a real thing, versus what is just like a secondary gut health thing. So really know what red flags are. Again, we don't know what we don't know. And the baby that was referred to me that had laryngeal malacia syndrome, something like this, the ped thought was reflux. Why? Because the ped doesn't have 2 hours to spend watching a whole feed. So if mom's just saying the baby's fussy spitting up, the ped has never sat to watch this baby like laboriously eat. So again, you know, I think it was Michelle was going to be saying that, you know, everyone has good intentions, but we all see different facets of the process. Okay. So, you know, fussy feedings can be symptomatic of bigger issues, right? The deaf baby, the baby with respiratory stuff, and it can create disorganization. Okay. And there's sometimes hard to diagnose, you know, different things. Okay. So, just taking away the triggers, just fixing the feeding stuff, taking out allergenic triggers, it isn't enough. Then the healing work has to begin. And there's a blog, it's called Cooling Inflammation. I think it's like a lactation consultant's husband's blog, so I sometimes read it. And I think he had a little analogy on there recently about if a zoo has one hippo and they want more hippos to come to the zoo, we can't just sit around with one hippo there waiting for more to come. And the same thing with a gut. You have to bring more hippos in so they can then start to reproduce. And if you have bad gut flora or the absence of good gut flora, you can't sit around waiting for it to come back home. You've got to go out and get it. And that's why like, the research around fecal transplantation and bringing healthy matter back into the gut, in some places in Europe, doing a rectal vaginal swab for the C-section baby and putting it in their mouth. And you've got to give the good flora, not just like wait for it to come to us.
Just repeat the name of the one.
Oh, well, it's called, I think, cooling inflammation.
Oh.
But I forget the guy's name, but I think if you Google that, you should find it. If not, you can let me know. And I just kind of, I'm not like, saying like that's a great website, but I like a lot of the stuff I read on it.
Right.
So once we started to identify, like, okay, here's some of the triggers we're working with. Okay, here's why this baby seems to be spitting up. We change the position, we change the flow, we change, maybe what mom's eating, and things are starting to get better. People are starting to get happier. But we still have some work to do to help heal this gut. And there's many ways to do that. These are just a few random things I threw up as ideas. I love a lot of the Chinese herbals, but I usually don't, and the Chinese medicine person that I collaborate with, usually don't start those like for teeny babies because it's strong medicine. So mostly the homeopathics, sometimes like gentle herbals. Then of course reintroducing the flora, probiotics, usually allergen-free. A lot of the ones you'll get at like New Seasons or Whole Foods are cultured on the base of lactose. And if you read the fines, and like may contain traces of milk. So if you just send moms out to get probiotics and she's diligently trying to avoid gluten or dairy or soy, she might be actually like actually directly feeding dairy back to her baby. So there's definitely some clinical brands you can get that are allergen-free. And even like Culturelle, which you can get at Walgreens, is pretty good. Moms can open up a capsule, dip their finger, let baby suck a little bit. So baby by baby. I'll often have moms consider doing a full spectrum enzyme for themselves, and maybe in older babies a gentler one. But for moms to start to digest their food a little bit better, so that they're not passing through so many offending allergens. Let's see. Good. And there's some, and on a personal note, I actually like classical or constitutional prescribing of homeopathics, but I put this up there as just sort of a, this is if you have this, try that sort of approach. But I love it when moms work with more of that classical approach, but, usually we're not going to do too much damage with homeopathics. If it just doesn't work, it doesn't work. And I love what Allison said. I will often also just kind of call in a flower essence, a tree, essence, gemotherapy, something, and I'll just kind of like have that energetically there, but not necessarily give it to baby.
We've also had really great success with using cell salt therapy.
Yeah, cell salts, yeah. And I forgot to put that under the umbrella of homeopathics, but yes.
And it eliminates the reaction.
Yeah. And for moms too, yeah, absolutely. And this isn't comprehensive, so I don't want you to think like this is it. Actually, I didn't even put like histamine on here. That's a fabulous one for like food type of histamine responses. But yeah, cell salts, and cell salts are great for so many things.
What are cell salts?
Can I do that in a minute?
Yeah.
Okay. Okay. But I also want to cover sort of the conventional side, because a lot of babies come into you might already be on this stuff, or there might be a time and a place where they need some of this stuff. So it's good for you to know what some of this stuff is. If parents are throwing around names and you don't know what they're talking about. And I have to say that I'm not a fan of sort of the, let's try this. Let's try to take the baby off breast milk and see if they improve. Let's try around with Zantac and see if they improve. I'd much rather have a better sense of, is the risk benefit of trying this worth it? Versus just, inherently doing more damage just for the sake of trying it out. Okay? Like, you're not going to just go smoke crack to try it out. You're going to kind of, well, I'm going to balance out some risks and benefits here. Not that I want to compare this to that. But so there's kind of two camps. They're of acid suppressors, and that's what the meds are. They're acid suppressors. They aren't stopping a baby from spitting up. That motion can still happen. They're just stopping maybe the acid from burning the tract as it comes back up. So babies might keep spitting on up, and parents are like, it's not working. But this is just sort of it. Now more than ever, the proton pump inhibitors, are being used and overused. Nobody in this area really uses the prokinetics like to help motility, but some doctors do. And certainly, so these are some of the medication ideas. And if you have to know, like, think of how are you going to give medicine that tastes nasty to a baby? And they're like in these mint flavored or like cherry flavored syrupy stuff with potential triggers in it, right? There's probably like some sugar and some flavor and some color that's like maybe going to add to this baby's gut irritation. So again, balancing out the risks, benefits, and sometimes I've seen babies, they're reacting more because they're allergic to something in the medication, right? And then some compounding pharmacies can make a non-lactose blend or something as well.
And Melissa, what about low-dose erythromycin? Is that happening around?
Well, none of that here so much, but there's absolutely some people that do better because it's a bacteria. You know, is there a bacteria we want to treat? And in adult patients, I see they do that more often.
They do it a lot.
Yeah, that they'll play around with, boy, can we kill off that bacteria and then reintroduce good stuff and get that out of the way. But I haven't seen it.
They're used for gastric motility.
Yeah, no, I haven't seen it around here. And anybody that has, please chip in. Maybe the hospital-based providers know more about that than me. I haven't ever seen a baby on that. Yeah. And then, you know, more of the non-medication ideas. The thickening of the feeds, again, controversial, because just because it goes down and sits there, you know, is that a good thing? And there's often, you know, starches or different things that's keeping that. And then how do we thicken breast milk and formula? So there's all of these things around thickening feeds. It's not used as much, but it's certainly done in some situations. Upright positioning, you know, there's even some clinical positions. They'll strap a baby prone on a wedge and strap him there so he doesn't reflux as much. And well, you talk about Tony time, he's getting a full day of it, for better or worse. And you know, sometimes the fungal application, sometimes they'll squeeze off a little bit of the fundus. I don't know. Yeah. So.
I think the FDA holds it.
Oh, yeah? Oh,
Good.
I mean, I think, but they might still use it with respiratory patients? I don't know. Yeah, as like a suffocation risk or something.
They pull the ones that you could buy in the
Yeah, for parents. I'm talking about like in hospitals.
The medical grade.
The medical group.
Yeah. Yeah.
Oh,
Oh,
yeah, from our pediatric grade, I think.
you can't do it anymore? Okay. And so I just want to just kind of stress that. Do we really want to cut down the stomach acid? Do we really want to suppress it if digestive problems are there? And again, like I said, sometimes we need a Band-Aid, sometimes baby is spitting up so much they can't gain, they're burning themselves so much that it's doing, you know, permanent damage. So, you know, we've got to weigh things. But when you really realize the dance of food entering, juices that get excreted, how everything is connected. When we take away one step, when we take away that acid and we suppress it, boy, now we're getting into trouble because now we're dulling the CCK release and everything else. So we're not just suppressing acid, we're suppressing kind of like the whole process. And some people say like, let's add more acid. And that's one actual strategy. Some people introduce some extra hydrochloric acid, but you know, working with a provider who obviously does that, and babies can be more tricky. So again, you know, when we mess with one thing, you know, we're messing with a lot of other things. Okay. I'm gonna breeze through this real quick. The whole let's try to baby off breast milk is often a first go-to for some doctors and providers. You know, there's so few reasons, you know, some reasons not to have that be your first go-to. If we can get mom to take away allergens and do that, sometimes that's not an option, right? Some moms maybe aren't there in their lives. It's not a possibility for them. It's asking too much. And some moms are like, yeah, just tell me what to do and I'll do it. So again, you have to know what's realistic for the clients you're working with. But some of the food protein-induced enterocolitis syndromes and different types of inflammatory things, it's not to me a reason to take a baby off breast milk. The baby is not allergic to the breast milk, the baby's allergic to something in the milk. So sometimes we might need to take it away long enough for mom to maybe clear that out, but it's not a permanent reason for a baby to get something else. And you know, very few reasons, and please, if there's any more that any of you can think of, break certain things down that are inherent properties of breast milk. You know, would be, and even with some of these cases, they can still have sometimes a certain amount of breast milk as long as they're monitored weight. And so, but again, just showing you that very few reasons to have a baby off breast milk. Okay, I don't think, you know, I want to respect people's time. I'm not going to go through the case studies, but what I would say to you is that on your own time, you can read through it, and there's no wrong or right answer to the case study. I just wanted to jog your feelings of, boy, if I had a little kiddo like this in my practice, where would my mind go? What would I want to start asking? What would I want to start thinking about? What would I want to start brainstorming? So again, they're not right or wrong types of situations. So we always have to kind of view the gut as the dyad, the mom and baby working together, and always honor the hard work mom's going through dealing with this baby. And whenever we can, like my goal is really, I have no feeding agenda, except that I want this mom to enjoy her baby a little bit. If they leave my office feeling a little bit more connected and happy about knowing each other, I think I've kind of done my job versus like solving all their problems in one setting. But just to have that healing presence is really empowering. And you know, our words and actions carry weight. And I don't like to flippantly throw around words that a mom might not know about. You know, oh, get somebody to psychotherapy, and oh boy, this might be hard. You know, because they like grasp on like, okay, what? Okay, what's wrong with my baby? What do I need to do? So be really careful about the words and how you talk. You know, be talking about babies' heads and breathing. I mean, that's gonna like freak parents out. Like, what? What's wrong with my baby's breathing and their head shakes? And so, you know, talk about things kindly and empower and educate those parents. And no, of course, it takes a team. None of us work alone, and it's one of the best things here, right? We all get to meet and greet and keep going with continuing ed stuff like this. Okay. So, ooh, I can't believe I did it in an hour.
You rock.